Welcome to today's webinar, sponsored by the International XLH Alliance. My name is Elizabeth Olear, and I am a clinical researcher at the Yale Center for XLH and Yale School of Medicine in New Haven, Connecticut. Today, we are here to discuss the unmet needs of adults with XLH and to support the call to action as set forth by the white paper, which was a collaboration between the authors, two of whom you'll be hearing from shortly, as they are on our panel, and the International XLH Alliance, representing the patient voice. Specifically, in the presentations and discussion today, we aim to substantiate the unrecognized burden of the adult complications of XLH as a lifetime disorder due to the underlying hypophosphatemia, and to promote comprehensive care and multidisciplinary management that follows a patient into adulthood. Much has been learned about XLH in the past 40 years, but there are still unknowns about the most recent advancements and treatment options and how these may impact XLHers for years to come. We'll see what needs to be done in the future and how we can join forces to advance research initiatives for this rare disease community. Following my welcome, you'll hear from Oliver Gardiner and Tenna Toft Sylvest from the International XLH Alliance, and then we'll move on to our panelists, Pol Harvengt and Professor Richard Keene, who are both authors of the white paper, Dr. Karl Insogna and Dr. Peter Kamenický. Following our panel, we'll have a question and answer and discussion of all the topics presented today, and then finally we'll wrap things up. And just a few notes for housekeeping. We do want everyone in the audience to know that questions can be submitted at the bottom of the screen by using the question and answer button. And we will save the questions until that discussion period, but please feel free to submit them throughout the presentation today. And if you have a particular question for one of the panelists or someone else, please make sure to indicate that in your text. Your mic and camera will be disabled. However, the webinar is being recorded and will be provided to everyone who has registered just as soon as it is ready. We will be putting the captions in and making sure that all the technology is appropriate. So we will continue on, and Oliver will be introducing himself next.
Hi, everybody. Thank you very much, Elizabeth. My name is Oliver, and I'm the chair of the International XLH Alliance. I'm also the chair of the XLH UK, and I'm also serving on the board of directors for the XLH network in the USA. I have XLH myself, as do 15 other people in my family, and that's spanning across 4 generations.
And hello, everyone. My name is Tenna Toft Sylvest, and I live in Copenhagen, Denmark. I have XLH. Unlike Oliver, though, I'm a spontaneous case. But I have twin daughters where one has XLH as well. They're now 4.5 years old. I'm the co-chair of the International XLH Alliance, and I'm also the chair of the XLH patient group in Denmark. I'm also on an EPAC on ERN Bond, which has to do with rare bone diseases. And I'm also part of the steering committee of an initiative that's called European Rare Bone Forum. I want to tell you a little bit about the history of the Alliance first. So basically, the International Alliance came together in 2017, where we met in Frankfurt, Germany. We were just a handful of patient groups from around the world at that point, who having met each other, realized that we could really see that the patient voice was very disconnected, and there was a lack of consistency. Some patient groups were very new. We all had very different experiences, and some were older and had possibly also more resources available to them. And we also felt that care across our countries were quite uncoordinated. So here's the solution, or what we came out of the meeting with, this realization that we actually had a really fantastic opportunity on our hands, that we could work together to really amplify the patient voices and create platforms where we could share our resources and educate both about XLH, but also developing our capabilities together, and also have a platform where we can actually share our experiences. We really also were wanting to help countries that are less fortunate than our own countries, and unifying all these patient groups. So this makes us able to both share our resources and make resources available for all patient groups. And all of this, of course, essentially comes down to that we really want to improve patient outcome for people with XLH, not just in our own countries, but also regardless where you live in the world. So today we are more than 21 countries from around the world, and we collaborate in the Alliance, and we're doing our very best to do what we initially set out to do, and do this solution together.
Thank you, Tenna. So I just want to really reiterate that we found ourselves in a really excellent opportunity here, where when the white paper came out, that we could actually use this to share our learnings. And we've really worked very hard over the last 5 weeks to manage our awareness campaign and explore the key and individual areas that patients feel are largely unrecognized. And this actually is quite a unique and profound perspective of patients across Europe. And we also know as an alliance that these are similar issues that affects people all around the world. And a part of this challenge, we felt that we really needed to debunk some of the issues that surround XLH in childhood and adults, and that is primarily around the fact that XLH is not just a childhood disease. This is something that is much more than causing rickets in children, and I think because of these bad connotations and connections has led to a lot of misconceptions in adulthood, and we're essentially wanting to ensure that everyone has a good understanding of the disease and the treatments that are available to them and their families. And also, I just want to also reiterate that patient organizations play a really critical role in challenging these misconceptions. So this is incredibly important for us to work on and develop from this paper. And so we're also here today to change that gear and raise the profile of adults with XLH and the daily challenges that really dominate the clinical picture of the disorder. It's important for us to really report on the impact of the manifestations and that it has on our daily lives of adults with XLH, and also be able to continue to develop evidence-based guidelines where we can actually change patient outcomes. So please help by contributing in today's discussions, because this is just the first stepping stone in driving forward and driving a support for our call to action.
Thank you, Oliver and Tenna. And thank you for organizing the International XLH Alliance. So our presenters today on the panel, I'll introduce them all briefly now so then we can seamlessly flow from one presentation to the next. First up is Pol Harvengt, who is chair of XLH Belgium. Paul is a patient and one of the co-authors of the white paper, along with Professor Richard Keane, who is a consultant rheumatologist from the Royal National Orthopaedic Hospital, NHS Trust in London, again, also a co-author. And then Professor Karl Insogna, professor of medicine and endocrinology, director of the Yale Bone Center, and associate director of the Yale Center for XLH. And then Professor Peter Kamenický, a clinical professor in the Department of Endocrinology and Reproductive Medicine at the Université Paris-Saclay in France. All right, Pol, I'd like to turn things over to you.
Thanks, Elizabeth, for the kind introduction. So I'm Pol Harvengt. So I'm XLH myself. Of what XLH is, but it's just my own view. And what I want to present to you today is the outcome of the work that we did recently around the burden of disease in adults. So before really digging into the subject, what I was wanting to highlight is that, of course, this was really a collaborative effort between professional medical experts, patient representatives, patient organization, especially in Western Europe, and the industry. So I think it's important to recognize the contribution. This multidisciplinary contribution was really exciting. And I was also wanting to emphasize that this is in essence what the Alliance wants to be, that is a catalyzer for the actors of the XLH community. So as an introduction, just a few words about XLH, make sure we are all starting on the same page. So what is XLH? XLH is a genetic disease caused by the mutation of FEX. FEX is a gene that is expressed in specialized bone cells called osteocytes. And basically this mutation inactivates the FEX protein, which in turn perturbates the metabolism of the bones and the endocrine metabolism as well. So this has two main consequences: an impaired mineralization of the bone and also a decrease of the blood phosphate. Actually, we only have a couple of treatment options, which are just mentioned on this slide. The first one is Rocaltrol or other vitamin D3 derivatives in combination with oral phosphate. But unfortunately, this treatment, even if it's used for quite a long time, is not able to correct the other hallmark of the disease, which is the over-secretion of FGF23. FGF23 is an hormone, so it's a factor which is secreted by the osteocyte and will just induce the release of the phosphate by the kidneys. So to address this last point, we now have another weapon, which is brosumab. Brosumab is in fact FGF. The main problem, I would say, or one of the issue is being that brosumab is not available to all the adults worldwide. Only a few countries it can be just available in a couple of different countries. So XLH is presenting with a lot of symptoms, as we know, and as you can see in this great figure, there are quite a lot of these symptoms which are shared between the children and the adults. The most prominent being the short stature and limb deformity that we most of us do experience. And as you can see on the right side of this slide, we also have a number of symptoms which are more specific to the adults. The fracture, spontaneous fracture, inflammatory disease like osteoarthritis, the anthesopathy, which is the growing of bones in joints, for instance. So basically, all these later symptoms most likely represents the long-term consequences of living with low blood phosphate and an excess of FGF23. And so now I come to the work that So basically, the work was made of two different parts. The first one is a literature review. We selected those articles that were dealing with two aspects. First one is the epidemiology of the disease, so meaning mostly the listing of the manifestation and symptoms of the disease, and also dealing with the broader subject of quality of life. And the second part was made of interviews of patients and medical experts that are in direct contact with adult patients. And the main goals there were to identify the unmet needs and the top priorities that needs to be addressed to improve the adult care. So that's for the methodology and the outcome of the study. We have now 3 publications. The central part is the medical paper, so that and you can see the reference of this medical paper published earlier this year in Osteoporosis International, the epidemiology of the disease. We have also a white paper with, which is basically a summary of both the expert and patient views. And we also have a poster which was presented earlier year also in international conference on rare disease, and which is basically dealing with the outcome of the patient survey. The white paper and the poster are available from the Alliance website, so you can access it as soon. And so before coming really into the reads and the outcomes of the study, I wanted to stop for a minute and just read or listen to what patient and doctor says. And so we have an example quotes of patients. So that's the first box, the blue box, that actually saying that the real issue started for him just before he turned 30. And that as of now, we can someday experience really extreme pain. So this testimony just says a lot about the subject. So it's not a mild condition that we're speaking about. We are talking about symptoms that can just really dramatically affect the physical and also psychological functioning of people. And in the second box, the orange box, we have the perspective of a clinician. What we can understand from this perspective is that the patient symptoms are really difficult to address. So in layman's terms, if I sum up what is reported here, we can see that the adult XLH seems to become old before the age, and that's not easy to address. And so the picture doesn't seem very bright, but let's look into the real detail of the study. So based on the literature review, estimate really the frequency of the symptoms in adults. This is what you see here on this scheme. So look into this box that are really reporting the different classes of manifestation of the disease. And if you look into the numbers, what we can say is that a vast majority of patients are, if we can pick up the bigger the bigger number in each of the boxes have both pain, physical function impairment, and also other problems like dental issue, abscesses, cavities. We can also say that a majority of patients can add, in top of that, problem with their muscles, so muscle weakness, muscle pain, even more dental problem like cavities. We also can say that about half of the patient report fractures or hearing impairment. And in rarer case, we can also have spine alteration, hearing loss, parathyroid activation, or so that's really a more comprehensive view of the problem. And when you ask patients how they would rate their quality of life, and you can see that on the bottom part of the slide, actually the average number that comes out is of their physical quality of life, and also some alteration of their mental functioning or their mental quality of life. So my personal view, and also if you remember the quotes from patients, is that it may even be a little bit underrated. So that's really very interesting, but also really intriguing numbers. So another aspect, of course, in terms of quality of life is also the economical burden of the disease. And so that's a very important aspect of the management of the disease, because yes, we don't have at the moment the tools for really quantify how much this disease costs to the society and to the individual and families, and that's one of the aspects that is really lacking in the knowledge about this disease. And when we are discussing with health authorities, that's something that really could help promote the point that we need to have increased standard of care available at reasonable cost, so fully funded by health authorities. If you look into the different classes of costs, so we have direct and indirect costs, and most here we have the beginning of the problem. We need to dig into this issue a little bit more to really come out ideally with numbers also, and potentially have these values to have this information as a point of discussion with the authorities that would help us also to being recognized as we should. So that's a little bit of a summary of the discussion that we have until now. So there are a lot of different aspects that are represent contributing factor for the burden of disease in adults. So we already just discussed about the disease aspect. So the pain, for instance, the problem with the mobility, the limited mobility of people, and we have also challenges both at home, at work as well, the financial pressure that we just talked about, and the lack of awareness, which is probably I was willing to do. And that's one of the outcome of the white paper. So we just asked the Western European patient organization to rank the top priorities that they see in terms of unmet needs for adult XLH. And if you look at the map, there are different colors. So, and what you can see is that in about half of the countries, critical and problematic point is the referral. So the access of patients to risk that can really continue to help them when they reach adulthood. Related to that is the awareness. So it looks also in several countries that we need really to increase the awareness of the HCPs as care provider in terms of continued care. We have more limited other aspects, but that's the main aspect. So in conclusion, so XLH in adulthood is really associated with quite some burden. Action needs to be taken to improve the lives of these patients, and also to ensure that they have access to care that they need. So we have action points for different sectors, for the patient organization, really to make sure that information, critical information, is available for HCP or other authorities, for the HCP themselves to review this data and to take that into account, make sure that we can end up with individualized care and the availability of multidisciplinary teams in different countries. And at the level of the policy make also, we could think about a lot of things that could be consider recognizing XLH as a real condition in adults. Ensure that we have enough specialized expert center in the different countries. Also the right to being recognized as disabled when the symptoms are really difficult to bear. And also, of course, we need to find new treatment options, and for doing that we need to have a strong research and to make research as it should be to make sure that this new knowledge can be translated into a new treatment option in the future. And so with that, I have to acknowledge a lot of people, my co-authors in the different publication. Okay, thank you. So you see the different names right now. And so thanks to all the contributors.
Thank you so much, Pol. Thank you very much. And we'll continue with Professor Richard Keane, another author for the white paper.
So hopefully you can see my slides. So I will, in the next sort of 5-10 minutes, I will just do an overview on sort of some of the challenges in the treatment of adults with XLH. By background, to say I'm an adult rheumatologist, but I specialize predominantly in looking after patients with metabolic bone disease. I was an investigator on the Brozumab clinical trial, and we've had some experience of using Brozumab in the UK through an early access program supported by Kieran. So I think as a patient group, I think one of the problems you have is that when we think of rickets or osteomalacia in sort of specialists or non-specialists in particular, the world is driven by vitamin D. So a lot of people will, if people present with bone-related problems, we're quite good at picking up vitamin D deficiency and problems related to that. But I think the issue is one that, on this list you can see here, phosphate deficiency is quite low down, and it gets missed by a lot of clinicians who are non-expert in the field. And I think that's one of the problems that leads to perhaps delays in diagnosis. And again, I think when we've looked at the data that Pol's presented, there are issues about the pathway and how patients will get identified in a timely manner. So I think actually understanding, and the next slide is supposed to be very busy, and I don't want people to get bogged down with this, but again, as clinicians, we pull bits of information together, and obviously we're looking at calcium levels, phosphate levels, vitamin D, but you can see that on this slide there's lots of arrows pointing up and down and whether blood results are normal or abnormal. So again, sometimes these things can be quite complicated and it's not completely clear cut. And again, that can create problems for patients in reaching a diagnosis and then getting access to appropriate care. Again, I think, depending on what country you're in, the access to your specialist test that may actually move you forward to make the diagnosis can be an issue. And again, so understanding, obviously, you'll have X-rays, you'll have blood tests, you'll have biochemical tests, and obviously at the bottom you can see, mentioning the FGF23. We heard from Pol how that's sort of an integral part of the disease pathophysiology, and again, in some centres you're able to measure that, but not everyone can measure that. And again, it depends whether you've got access to that sort of expertise in the laboratory. And then obviously, with the advent of the identification of the FEX gene, obviously actually being able to then confirm whether someone does carry that genetic change obviously helps make the diagnosis. But again, that depends on the resources your healthcare sort of setup has, and whether they will actually fund the genetics. We know that a lot of older patients with the condition is based just much more on family history and some of the more other areas. But actually, if you've got access to genetics, that does make a big difference. And again, this is just a panel of of genetic tests that we can get here in the UK if we want to. So if we're suspecting a genetic cause for hypophosphatemia. I think one of the things as an adult physician, and again for the patient community, is basically how are adults with XLH going to present. And I've just put sort of 4 things here, and again, I think the top one is really important, and it's probably something that, again, I would really encourage forums like this to really drive and improve, because I think transition from paediatric services is really critical, and again, that's going to be even more important, I think, with the fact that a lot of pediatric patients in countries now are getting access to Borozumab. I think just actually making sure that transition happens in a seamless way. There are challenges. Again, I think you may find that a lot of the children are being looked after by endocrinologists and pediatricians, but actually, as you'll see, as we've heard from Pol as well, a lot of the adult manifestations and problems of the disease, can be sort of more musculoskeletal. So again, I think it's trying to find out who is the best person to be looking after you as an adult. Again, you'll still see some individuals who get identified because actually their disease has been quite mild in adulthood, and actually it's only when they have a child and people go back over the family history that you may find that that's a thing. So again, I think it's actually making sure that your children have access to good services. I think, again, one of the issues that happens to a lot of patients, again, perhaps through the transition phase, but also just as they go into adulthood, is perhaps they didn't get access to the right physician, and so they get lost to services, and again, perhaps they're then suffering silently, and they've got manifestations of the disease, and no one's picking that up, and the patient says you're not aware that there's a problem, your doctor isn't, and actually, again, it's trying to join up the specialists with the person. And again, sometimes you're lucky that you may be in a hospital setting having something else, another procedure, and someone recognizes that that there's something wrong with a blood test or something, and then you'll get put into that pathway. But I think it's critical. I think forums like this are really important to drive the improvement in the care pathway. You don't want to suffer because you live in one country versus another. And I think the Alliance is very good. There's obviously the European Reference Network, which is a forum that is being put in place. Exactly where the UK is going to sit in that after the end of December, we'll have to wait and see. But again, I think having these pathways to improve access to care and to try and get consistency in care is going to be really important. Again, this is almost lifted from a medical textbook, but again, I think what's really interesting is that what we've identified in the white paper and in some of the reports that Pol presented is that the sort of the main clinical features of the condition are basically identical to what patients are saying about what the burden of the disease is. Again, I think the only thing that isn't picked up on this, and again, I'm going to be a bit cheeky because I've spotted one of the questions, but I think again, what we do realize is that there is a big sort of social impact as well of the condition. And again, I think that's really important, that we're not just looking after the bones and the joints and the muscles, that there's a much wider manifestations of the illness. And actually, again, having a multidisciplinary team to tackle all of this is actually what's really, really important. And there are sort of deficiencies, I know, in some services, and we do need to do better to give patients that more holistic care. And I think that is one of the challenges. It's not just about the drugs. There's a lot more else that we need to do. With regards to treatments, again, we've heard that, from a lot of patients up till now, the mainstay of treatment has been activated vitamin D, so calcitriol or alpha-calcidol with phosphate supplementation. We know obviously that in children that is often given. For adults, again, with prolonged treatment, there are complications with the disease, with those drugs, and these are sort of listed here. So we have to be careful with the activated vitamin D about hypercalcemia. There's risk of kidney stones, and then sometimes because of high calcium levels in the blood and issues related to that, and phosphate supplements, you can get abnormalities from some glands in the neck, and again, that can sometimes cause particular problems. Again, I think for adults, because of the complications of the condition, we're often treating people on the basis of just having pain symptoms. That's been the sort of the recommendations generally. I think, again, with the advent of something like Borozumab, that may open up more patients to be treated, because perhaps patients are either underplaying their pain, their quality of life, because taking the tablets, is not always the most convenient thing to do. So again, I think that we need better data to understand the longer term effects of these drugs, because as you can see, for the conventional drugs, we don't really know whether they're going to make differences to some of the longer term complications of the condition. Last year, there were these sort of summary of recommendations and guidelines for how you should manage XLH. And again, I think although these are sort of consensus based, so that where you get sort of doctors in a room and they sort of review the evidence and they come up with some guidelines, I think they do give some sort of standards which can be adapted and used, and hopefully again these will provide some way that you can get some consistency of care across sort of countries and across centres, and then hopefully that will also basically, one, improve the outcomes for patients, but also will enable us to actually perhaps answer some of the questions about the longer term impact of the disease and the treatment, because as we've heard, sometimes trying to get some of the cost effectiveness data is quite challenging, but actually if we can get more robust data from the clinics in a consistent way, that should help. Again, I just pulled out, this is what they've come up with, what should be happening for adults. And again, I think one of the things for the patient community is if you know the sort of things that are being recommended for, what sort of assessments should be having, how often you should see your specialist, if you can sort of, then that can help drive improvement in quality, because you can be basically ensuring your doctors hopefully are delivering this sort of these sorts of assessments at this sort of recommended frequency. This is again quite a busy slide, and I don't think you need to worry about it, but again, there are again, what you can see from this really is if again, you can read this at leisure when the recording, but the statements are sort of, you can sense that we're not 100% certain. So certain things are are sort of, we suggest treating, we recommend. There's not 100% guarantee about things, but overall this gives a framework, and I think a lot of experts will be doing this. But again, I think it's just trying to, if we can pull information about the number of patients we see and we do things, then that will just help us gain sort of improvement. But the biggest thing, and again, we're going to hear more, I think, from some of the other speakers about some of the other complications of the disease and issues thing. But I think the biggest thing with all of us is obviously, not only do we want to, make sure that you're in a clinic getting good care, but obviously the treatments we hope are going to reduce some of the complications, not just ones that occur in childhood, but those that also happen as we all get older. And I think with that, my 10 minutes is up. So thank you very much. I will hand you back, and we look forward to the next speakers. Thank you very much.
Thank you so much, Professor Keane. I have to say, while we wait for Dr. Insogna to bring up his slides, both you and Pol bring up such wonderful points. Obviously, Pol brings the patient perspective along with being a scientist to the table, but the points about mental health being such an important and integral component to the physical manifestations of the disease. Whenever we're talking to patients or I'm talking to patients, I always kind of talk about XLH as a whole body, whole life disorder. And I think we can see that in many of the points. And hopefully during the discussion, we'll get a chance to go back to talking about transitions of care as well. But Dr. Insogna is ready, I see, and I'll pass it over to him.
So I don't know whether you heard me, but I just wanted to thank the organizers for inviting me. So I think what I want to do is talk about where we go from here based on what we just learned from our previous speakers and what was in the white paper. So we know that the burden of disease for people now living with XLH is substantial. 3 recent studies have documented this in adults. The seminal paper we just heard about that was published in Osteoporosis International, another study from Lowe that was published earlier this year, and a third study by Sungar published last year. And what those tell us is what we learned already, which is the socioeconomic impact of this disease will remain substantial for adults. Enthesopathy will continue to be a major problem for many middle-aged and older individuals with this disease. Dental disease is likely to persist in adults. Hearing will not be restored in those who have lost it. Difficulty with ambulation will persist in adults, and surgery for joint disease and spinal disease will still be required. Going forward, some of what we need to know but don't yet know is an ability to precisely quantify the impact of XLH on the emotional development of children and its impact on self-esteem, which I think translates into important negative effects in adulthood. We need a prospective study of spinal disease, particularly posterior longitudinal ligament calcification and spinal stenosis, which are devastating complications of the disease and not infrequent. We need to better understand dental disease. We need to better understand hearing loss, tinnitus, and that means that we need a prospective study to understand when it develops, what symptoms develop, and what we can do to prevent them. As has already been emphasized, we need a consistent multimodal approach to pain management, and I'll come back to that. We need to clarify the role of burosumab in treating adults with XLH, and should there be a drug holiday in early adulthood? And we need to develop and engage patient advocacy groups in other parts of the world besides the US and Western Europe. So I'll just touch on a few of those points. The review that was just summarized for us by Paul and Richard highlighted the fact that 70% of adults take pain medications and nearly up to a quarter of them take opioids. And this is a real problem because opioids are very helpful for acute pain, but increasingly pain management specialists tell us that long-term opioids are not as effective for chronic pain. And so I think we need to have a much more nuanced, a much more comprehensive approach to how to deal with the pain that many patients with XLH suffer chronically. Dental disease. Dental disease starts in childhood. It's devastating because nothing can be worse for self-esteem than developing bad dental hygiene in your formative adolescent years. We know that there are structural abnormalities in the teeth. The pulp chamber is widened. The dentin, which is the layer of bone next to the pulp chamber, is abnormal. But the enamel on the very outside of the tooth is actually normal. And I believe that some of the problem may be with the dental ligament that attaches the tooth to the alveolar or mandibular bone. We do know actually that conventional therapy, at least based on cross-sectional studies, if given lifelong, seems to ameliorate dental disease in adults. However, there are no clinical trial data on the use of sealants, the use of aggressive treatment to prevent periodontal disease, and the efficacy of antibiotics to treat the all too frequent apical abscesses that occur in this disease, and how best to use them. We've already heard about enthesopathy, which from my perspective is one of the most devastating and debilitating complications in adults. And this is, as Richard already pointed out, calcification of ligaments that are around joints and limit the mobility of that joint and cause chronic pain. So here we have a patient with severe enthesopathy. And these entheses here will basically prevent this person from moving his hip very well. It also occurs in the elbow joint. You can often tell a person's dominant arm with XLH because they can't hyperextend the arm on that side. And we see this developing relatively early, first at the Achilles tendon, where we can see these changes as early as 18 years of age. And this is something that occurs progressively through life. This is from that cross-sectional study in the Journal of Endocrinology, the Endocrine Society, that shows that even by age 31 to 40, these are patients reporting enthesopathy. These are not patients for whom this condition is pre-symptomatic, but patients who are aware of enthesopathy. Fully a quarter of them are aware of it. And by your middle age, up to a quarter of patients will have spinal stenosis. Again, these are just patients that are aware they have it. I don't routinely screen for this. Most people don't routinely screen for changes in spinal anatomy. And it's something that I think we definitely need to do more often, as I'll come to, because there's increasing awareness of back pain now that we have burosumab. So I'll mostly focus briefly on burosumab. We've heard a little bit about it. We know that calcitriol and phosphate therapy does actually improve the osteomalacia, and as I mentioned, does seem to ameliorate dental disease, but burosumab does so more rapidly and heals fractures and pseudofractures probably more effective than conventional therapy. And this slide summarizes the most important data from the registration trial for burosumab, which was a randomized trial. And in the first half of that trial, the green line shows you the complete healing of fractures that were identified at baseline in the patients who received active drug, that is burosumab. And the gray line shows you the fracture healing in the patients who only received placebo. And by the end of the first 24 weeks of therapy with active drug, more than 40% of the identified fractures in the burosumab group, of which there were 65, more than 40% of them had healed. And the healing continued throughout the second half of the study. As you know, at the end of the first 24 weeks, the group with placebo were crossed over to active drug. Nobody in the placebo group actually knew what they were getting, so they didn't know what they were crossed over to. But what's really striking to me is that they healed their fractures at the same rate that people who got active drug. And so at the end of those 24 weeks of crossover, 35% had completely healed their fractures and nearly 40% had partially healed their fractures. So while we know that burosumab greatly improves and in many cases nearly normalizes blood phosphorus, improves how people feel and function, and helps heal fractures in adults, we still don't know if it will normalize height, allow for a drug holiday in young adults, prevent dental disease, prevent hearing loss, prevent enthesopathy. We also need to better understand the etiology of the restless leg syndrome that occurs in patients getting burosumab, or what causes the transient back pain that occasionally occurs at the onset of treatment and results in people starting to get imaging of their spine. Finally, many of my adult patients describe that they feel stronger with burosumab, and that particularly in young patients, a mental fog has lifted. We never can document obvious muscle fatigue in adults with XLH. But what this study shows us, there may be an actual physiologic basis for that. So this is a study we did looking at the rate of energy synthesis in muscle. And it's basically the rate at which the muscle accumulates high energy storage in the form of ATP. And the green straight lines show the normal range of the rate of energy synthesis by normal muscle. This is a patient, this dotted line shows you a patient who did not have XLH, had phosphate wasting for another reason. And when we repleted that person's phosphate, their rate of energy synthesis in muscle normalized. It came up into the normal range. So we're interested in knowing whether some of these complaints of fatigue that patients with XLH have may actually have a basis in how their muscles are synthesizing energy. Finally, I wanted to touch on this issue of international collaboration, which was highlighted to me by a postdoc that came to my lab a few years ago to have me help her with a cross-sectional study of 261 Chinese patients with XLH who were evaluated at one center in China, the Peking Union Medical College. So in one center, they follow more patients that were recruited for the international phase 3 registration trial of burosumab in adults conducted at 25 sites in North America, Europe, Japan, and Korea. So clearly, there are a lot of patients out there that we don't know about. And so our challenges are we need to strenuously advocate for more research into the basic pathophysiology of this disease, both government and industry funded. And some of this is a little technical, but as you heard, the mutation in this disease is due to an enzyme, a loss of function, an enzyme called PEX, or I guess in the UK it's FEX. And we think, but don't know, that one of the targets for that enzyme is degrading a series of proteins called sibling proteins. If they're not degraded normally, it leads to the accumulation of peptides called ACE-arm peptides that some people think plays a role in XLH, but that's all been work done mostly in mice, not in humans. As I said, we don't understand the pathogenesis of the dental disease. And as we'll hear in the next presentation, as I become increasingly concerned, secondary hyperparathyroidism may be an important co-conspirator in this disease. Ultimately, enzyme replacement therapy is our goal for cure. This is a single gene mutation in a single protein. And although we don't have the technology to replace genes that are defective in skeletal tissue, we have the technology to do it in hematopoietic tissue, and we may soon have the ability to do it in tissues other than hematopoietic tissue. The socioeconomic burden of disease reflects in part the impact on emotional health and self-esteem in childhood and adolescence. And I think that translates into difficulties with socioeconomic status in adulthood. And these issues need more highlighting and more study. Many individuals with XLH, as we've heard already, are not receiving proper care. We need to continue to increase awareness through meetings like this. And we need to develop and partner with advocacy groups in South America, Asia, Australia, and Africa. And I was particularly struck by meeting a young woman from South America who can't even get phosphorus to treat her XLH. So thank you.
Thank you, Dr. Insogna. You raised so many points and given us so much to think about. I hope that we'll be able to bring all these back up during the discussion period, especially with regard to self-esteem, economic burden, the dental complications that affect so many, and of course, endotheliopathy. As you mentioned, we'll be hearing from Professor Kamenický about hypoparathyroidism.
So I'm going to continue with the endocrine and metabolic complication in XLH. I will start with this case, 19 years old boy who I have seen on my transition clinic with diagnosis of XLH in the early childhood. He has been treated with both alpha-calcidol and phosphate during childhood and adolescence. And he had femoral and tibial osteotomia at the age of 18. This is his height and his body weight. And you can see that at the age of 19, he develops hyperparathyroidism with mild hypercalcemia, really low phosphate levels, and this is the PTH, this is the vitamin D concentration. The PTH was elevated in him. So this is just to demonstrate that we have hyperparathyroidism in some patients with XLH. And when we looked at the literature, there were several case reports and 5 rather small retrospective studies. And that's why we looked with Annelies Lecoq in our department to our cohort of patients. You can see here 68 patients with XLH, adult patients. And this is a control group from a cohort that is called Variété that were matched for age, sex, and also for vitamin D status. And what is important here is these results that actually compared to the control subject, the PTH concentrations in patients with XLH are clearly elevated. The serum calcium concentrations were comparable. This is the vitamin D status, which is obviously the same in patients and in controls because they were matched. But also the calcitriol concentrations were similar. And this is creatinine concentrations, just to show you that actually patients with XLH have lower creatinine concentrations. And this is not because they have better renal function, but because they have a lower muscle mass. So we can conclude actually from this that 25% of patients with XLH have actually increased PTH concentrations, and this is irrespectively of vitamin D status. So secondary hyperparathyroidism, which is probably due to the disease. When you look at the pathophysiology of the hyperparathyroidism in this disease, in gray you still have the controls. So the relationship between PTH and calcium, which is rather negative. The higher the calcium concentrations, the lower the PTH concentrations normally. But in XLH patients who are in blue and in red are those who had hypercalcemia, either already operated or before operation, parathyroid surgery. You have a disruption of the normal relation between calcium and PTH with higher PTH concentrations for higher calcium concentration. So there is something going on the relationship between PTH and calcium on the parathyroid function, which may be due to abnormal calcitriol synthesis, which is also very often cited in the literature, but I'm not so sure that it's really true, is the treatment and over-treatment by oral phosphate salts. It may be also the role of the FAX mutation in the parathyroid tissue that actually disrupts this normal PTH secretion, and maybe also the role of excess FGF23. There is also abnormal relationship between PTH and serum phosphate, but I'm not going into this because of the time. 10% of our patients with XLH had hypercalcemic form of hyperparathyroidism, so higher calcium concentration than normal. You can see here the calcium concentrations were actually slightly increased between 2.6 and 3 millimoles. So it's not severe hypercalcemia, but still hypercalcemia, which is not very advantageous for the patients. They had obviously higher PTH levels compared to controls. And what is very interesting, they have clearly decreased phosphate levels compared to other patients with XLH without the hypercalcemic form of hyperparathyroidism. So actually, the hyperparathyroidism is a complication of the disease that clearly worsens the hypophosphatemia. And they had higher urinary calcium and creatinine ratio. This is just to show you that if you compare the 7 patients with hypercalcemic form of hyperparathyroidism with the patients that do not have hypercalcemic hyperparathyroidism, there was no difference in the anamnesis of the treatment during childhood, especially with phosphate salts, neither in the ongoing treatment modalities. And if you look at the complications, we were quite surprised, but there was no difference in nephrolithiasis, but the numbers of the patients are not very high. There seems to be a little excess in nephrocalcinosis, which was not statistically significant in the group of the hypercalcemic hyperparathyroidism. You have here an images of a CT scan of the kidney in a patient with hypercalcemic hyperparathyroidism and XLH, and you can see this calcification in the renal tissue. So all the 7 patients have been treated by surgery, and I'm not going into this imaging before operation, just going to comment on the modality of the operation. But before starting this, I would like to stress that obviously we operated on these patients because we have easy access to a specialized surgeon. There might be countries where the specialized surgeon is not so easily available, so medical treatment options are also a possibility. I'm going to comment on this. All the patients had cervical exploration of all parathyroid glands. Selective parathyroidectomy has been performed in 5, subtotal parathyroidectomy because of hyperplasia in 2 patients, and 1 patient had reimplantation of the parathyroid gland in the forearm. 3 had adenomas, 3 hyperplasias, and 1 had actually adenomatous hyperplasia. This is the histology of the parathyroid lesions. So in 3 patients, we actually observed parathyroid hyperplasia. And for the moment, we didn't see any recurrence of the disease after the surgeries. This is reassuring. 1 had this adenomatous hyperplasia, where you have a hyperplastic gland with also already some adenomatous or pseudoadenomatous formations. And then here you can see typical chief cell adenoma. This is the oncocytic variant of a parathyroid adenoma in 1 patient, and 1 patient had atypical adenoma with, you can see here, spots of adenomas already in the capsule. The outcome of the surgery was very good. Actually, all patients normalized, and for the moment, all have normalized calcium concentrations, decreased and normalized actually the PTH concentrations. And this is interesting. You can see that after the surgery, the phosphate concentrations also increased. This is just to comment on the therapeutic options in patients, in those who you are not going to propose operation or who will deny operation. And I think that a very interesting data is from this paper by Karl Insogna in JBMR, showing that actually patients on Burozumab over the treatment decrease their PTH concentration. So maybe Burozumab would be an interesting option in patients who have secondary hyperparathyroidism or tertiary hyperparathyroidism. And just to finish, four slides on the obesity. This is another case, a patient who is very short and whose BMI is clearly increased, 42. And actually the family is already like this. You can see that his father is diabetic, has increase in BMI, and her sister also has an increase in BMI and diabetes. She's not diabetic. So this is our recent data, 115 patients with XLH from our center, adult patients, and you can see that the median BMI here is at 26.8 for all patients. And actually, it's not very different from the French population. But the problem is that here you have much younger patients than the general French population. And you can see that there are many patients who are overweight and who have obesity, even severe obesity. So if you look at this data differently, this is the distribution of the obesity in the French population according to the most recent data that we have, according to the sex, the men and women, and to the age categories. And you can see patients who are lean, who have normal BMI, who are overweight, and who are obese for each age categories. And you can see that in the XLH men, but also in women, but it's less pronounced in women than in men, you have excess in overweight and obesity in the younger categories. So this is something that is important. Finally, the metabolic status of this patient is also interesting. So we have the glucose metabolism that was assessed in 106 patients. And you can see that actually, despite of the excess of body weight, actually the glucose status is usually normal. We had 10% of the cohort who have a glucose intolerance assessed by OGTT. And less than 4% of diabetes, which is approximately what is expected in the French population for 106 patients. So I think for the moment, but we need to analyze this data more in details, that actually we have clearly increased body weight in some patients and in younger patients, but it seems that this would be metabolic, healthy kind of obesity without excess of metabolic syndrome. And I thank you for your attention.
Thank you so much, Professor Kamenický. That's fascinating, and I know that many of the patients that we've spoken to over the years have been particularly interested in the components of XLH as it pertains to hyperparathyroidism, and more recently even obesity, especially as the decline in mobility seems to make moving more difficult. And so now we'll turn our attention to our discussion. And before we do, I do want to mention, besides what was discussed by the panelists and whatever it is that we discussed during this Q&A session, that none of what's discussed, we will not be endorsing any one particular treatment. However, the discussion may touch upon the options that are available. So let's see the questions that have come in. So we have a question about the multifunctionality of symptoms and presentation in adulthood. And the question is, what is being done or can be done to make sure patients have access to comprehensive and accurate information from diagnosis without having to find it themselves? I think it's so common for patients to feel like they are looking for information, and maybe even sometimes when they see a consultant or a clinician, that they're bringing all of the research that they have done to someone just because it is a rare disease. But I'm curious to know, how our expert panelists find this question.
I mean, I'll kick off. Yeah. I mean, I think it's very difficult, and I think this is, as you sort of mentioned in your little bit of summary there. I think, for patients with a rare disease, it's pretty much a very common complaint across the board. I think whichever the diseases we see, I think the journey that the patient takes to get to see the right specialist, that they can end up seeing several, or even a large number of different doctors. I mean, education of the medical professionals is really important. And again, I suppose it states things like the white paper, although it's, it has a target, or the audience is going to be quite wide. So obviously targeting medical professionals to try and raise the understanding of these conditions is really, really important. And that goes back even to, training people in medical schools, because again, if they don't get exposure to these conditions when they go out into the big outside world as medical professionals. So I think it's we're all on a journey. I think, the patient community, that the medical profession is definitely improving, but it's slow, and unfortunately, sometimes patients do feel they're in a battle sometimes to get referred to the right person. But I think it's just trying to highlight, and again, I think forums like this, where people are trying to identify, in a region, in a country, who are the specialists that you should be going to, and it's about communication, and for us as the specialist centres to be disseminating information. I think sometimes, again, when there are treatments, perhaps referral pathways improve a little bit, because there's someone needs to, governments get interested, about the paying of the drugs, and so there are. I think that there's an opportunity to improve services, but yeah, it is difficult. We can do better.
Thank you. And I was even going to maybe suggest that the patient advocacy groups, patient support groups are wonderful resources to patients who are either newly diagnosed or looking to find out more information or the latest research in the United States. We have the XLH network, obviously the International Alliance, the International XLH Alliance is a patient organization that encompasses many of the country-specific patient support groups, and perhaps, not only can they be a source, but they can also work together with the expert centers.
Yeah, and I think in Europe, I mean, as I mentioned the European Reference Network, so that's a sort of a group of hospitals and clinicians that have got expertise in managing a number of rare bone diseases. And again, I think it would mean that patients, although they still have to do some of the homework, if they knew where those doctors are working, then they can hopefully get to them and get appropriate care and management.
Is that's ERN bond?
Yeah.
Is that what patients would look up if they're okay?
Yeah, ERN bond. Again, I think ERN bond, but again, XLH would also come on. Sometimes it comes under the ERN from an endo, so endocrinology. So again, it highlights that there's a slight sort of there's different clinicians from different parts coming in. But yeah, ERN bond, which is for bone disease, and ERN endo.
Oh my goodness, we have quite a few questions coming in about Burosumab. Let's see if I can group some of those together. So there's been, and I've seen this in some of the other forums, we've come off a number of patient organization days and family days, both in Europe and in the US. But there's lots of questions about spinal stenosis and what can be done either to prevent it, or if the treatment can advance it and cause it to worsen. So I'm wondering if Dr. Insogna might have an answer to this question or perspective.
Well, the short answer is we don't know. The problem is, as I sort of alluded to, that now that there's a bit of an ascertainment bias, now that at least in the US and places where it's approved for use, patients are being seen more frequently. Their symptoms are being more paid closer attention to. when they're on a new drug that we don't know everything about. And so in the past, on conventional therapy, when people complained of back pain, we said, well, that's kind of the natural history of the disease. Now, when patients, particularly when they get started on burosumab, particularly if they get started at 1 milligram per kilogram, which is the starting dose, not infrequently people will have an episode of back pain, probably not pathogenically related to spinal stenosis. But what happens is when they have back pain, people start getting films and then they start finding things. So the pathogenesis of the spinal stenosis is multifactorial, and maybe Richard will comment as well. This posterior longitudinal ligament calcification is a contributor, very concerning, but there's also advancing osteoarthritis that contributes. So there are multiple factors that contribute. It's pretty clear that once those are present and calcified, it is unlikely, at least in my opinion, that burosumab is going to reverse that. There's no reason to believe it's going to worsen it. The only data we have that bears on that directly, we're looking at the extent of Achilles tendon calcification during the 1-year trial, and that did not worsen. For whatever that's worth, it suggests that there wouldn't be a rapid worsening. Pathophysiologically, it doesn't make sense it would be rapid worsening. I think it gets to the broader question of the underlying etiology of the enthesopathy and this calcification of the ligaments. I personally ascribe to the theory that this is simply a response of the body trying to affix a ligament to an unstable surface, to a soft bone. And if that's true, then we should be able to prevent its progression by treating before it becomes calcified. And I know Tom Carpenter at Yale is interested in doing a study to see whether we can identify what we might term metabolically active entheses before they calcify and see whether we can intervene. But all that speculation, the short answer is we don't have the data yet. As I sort of suggested, we need prospective data, cross-sectional data, and prospective data looking at how frequent this is and how often and how rapidly it develops.
And I think, I think there's some concern too, because if you read the packaging for burosumab, it does indicate that one of the maybe adverse events during the clinical trials was worsening spinal stenosis.
Right. So that is clearly a part of the natural history of the disease. We have seen that in the past. I have seen patients over the years who have required surgery for spinal stenosis. So it's part of the disease. Whether we don't just have enough data to know whether it attenuates it.
Okay, thank you so much. We have a very timely question with regard to COVID. And so someone is asking, are there any additional impacts from the ongoing pandemic, either related to treatment, canceled appointments, canceled surgeries, difficulty getting medicine, or any component of having XLH that would increase the vulnerability or susceptibility of someone acquiring COVID? I think many patients may have heard that low vitamin D may weaken someone's immune system, or maybe having low vitamin D may make you more susceptible to viruses.
Well, my own view is that there's no evidence, no compelling evidence that low vitamin D levels put you at risk for COVID. I think low vitamin D levels are something to be avoided in XLH. By vitamin D, we mean the precursor form, what you measure in the blood, not the active form. Certainly, we want to keep that value normal, and people who are on burosumab tend to chew up their vitamin D more quickly than other individuals, so you need to pay attention to that. But my own personal view is based on the data I've seen so far. I don't think there's any compelling evidence that treating with excess vitamin D attenuates the COVID disease or prevents you from getting it.
Yeah, I'd agree with that. In my reading of the data, I think again there's been a lot of media interest in that, but I think again the evidence that supplementing with high doses is going to reduce the COVID risk isn't there.
Thank you. So there was a question for Professor Kamenický about hypoparathyroidism, and with regard to the treatment. whether or not treatment with burosumab would actually eliminate the experience of hyperparathyroidism in patients, especially those who may have seen this as a result of a previous treatment.
So eliminate, I don't know, but from the data I have shown you from the CL303 study and its extension, you can see that there is actually a decrease in concentrations of PTH, who were quite high actually on the beginning at the baseline. They seem to decrease. So maybe with the treatment by burosumab, you can lower PTH levels with the apoptosis of parathyroid hyperplasia. This is a supposition. I don't know if this is really true, but it seems that PTH levels decrease in this study and its extension. I think that Karl can also complete on this because he's the first author of this paper. But this is the first observation that we have. So for me, hyperparathyroidism, especially in patients who are not going to be operated, would be also a good reason to start burosumab treatment in a patient who was on conventional treatment, in an adult patient on conventional treatment.
Thank you. We were talking a little bit earlier, and it was mentioned in a few of the talks about transitions to care. And obviously, we know that XLH has been considered for a long time to be a disease of childhood, whether or not that's because of the focus on rickets, which is, a condition that we talk about while the growth plates are open and while a child still has the ability to grow and increase in height. But a question came in actually thinking about the other age of the lifespan and talking about what care is appropriate for seniors and people in their later years, especially as symptoms may increase and it doesn't seem to be a lot of information of how to treat someone who is a little bit older. The attendee is asking if there's any specific advice or if there's anything for older XLHers to be aware of and consider.
I mean, I suppose, the older the patient, the likelihood is that they'll have had, well, their treatment regime is going to have been different just because of what over the years, what they've had. So their accumulation probably of, other illnesses or other complications of the disease will be a little bit more. I suppose I wouldn't be treating anyone any differently. I suspect the only thing would be that you might need more multidisciplinary input from sort of like with regards to physiotherapy and things like that, because there may be sort of aids and things that they might need. But I think from a general view, I think you'd just be taking a very holistic view because of the types of things that they would have had affecting them. So I wouldn't treat them. I don't think there's anything different. I think you just got to look after them because they'll have the sort of the accumulation of disease damage, but also just the accumulation of aging and other comorbidities. So those just need to be taken into account.
I also think it's one of the hardest things to do if you have XLH, and probably one of the most important things to do is try to keep your weight down. Extra wear and tear on your joints from weight bearing accumulates and is a problem. And I think I always try to emphasize to people that remaining fit within the confines of what they can do is important, but not pounding on your joints. So, I always sort of recommend swimming or an elliptical, but, some of my younger patients or even middle-aged patients want to jog. I'm not usually a huge fan of that. So I think weight is an important thing. And I think, as Richard said, the other thing that's important is, don't go seeing a physical therapist that wants to increase your range of motion at joints that you simply can't increase your range of motion at. You need to understand the limits of what you can do in terms of the calcification of your ligaments. But within those limitations, I think it's important to stay as fit as you can.
Yeah, because I agree. Because I think also, again, this might be a slight bias from, my institution where I work, but a high, as patients getting older, there is a high incidence of them needing, or ending up with joint replacement surgery. So again, I think, looking after your weight and doing the right sort of exercises is really important, because that's the those are the complications that you're going to end up getting if things, if your weight goes up and say you haven't looked after your joints.
I almost feel like that physiotherapy should be a part of the treatment plan for all adults. So when you go and see the doctor, you also see a physiotherapist at the same time, or one is scheduled in, and you see that physiotherapist every couple of months, as you would see the dentist, as a way to kind of control and slow the enzopathy, which is shown to be so so bad for people with XLH.
Yeah, and I think Oliver, I think that's very good. I think one of the challenges is, in our clinics in particular, it's trying to get the physiotherapists. Sometimes, in other rare diseases, we've managed to get a physio working alongside us in a clinic. So in a setup like this, we in now these COVID times, we have a virtual clinic, but we'd have a physiotherapist with us. I know, again, in the UK, there is a drive that perhaps some of the sense, because there's a lot of overlap with other rare diseases, that you may end up being able to have a physiotherapist in. But again, sometimes it is resource dependent. But again, I think, if you're looking at holistic care, it would be important.
I think that's so important, and one of the things that I think we wanted to come out of this webinar is to really not only recognize the unmet burden of XLH, in adults, but to really understand how we can move toward a more multidisciplinary approach to care throughout the lifespan. I did want to mention before we take another question, just that we are, in the interest of time, we're coming up on 5 minutes until we said that the webinar was going to end. And I absolutely want to be mindful of the panelists' time. I know it's getting very late across Europe and in other parts of the world. The response to the webinar has been extremely positive, and so many questions have been coming in. I honestly am having a little bit of difficulty keeping up with all of them, and I know that we'll probably want to get answers to everyone. So I hope that there is a way. I've been trying to actually copy and paste and not having very much luck, but there's so many topics still for us to continue the discussion. I think perhaps we'll maybe have to start wrapping things up, and then just know that because there's so much interest, because this is such an important topic, that it'll be something that we'll need to continue sponsoring platforms such as this, so that we do move forward with what we've discussed so far and what we need to do to move the care and the research forward. So I think with that being said, I would like to thank all of our expert panelists for preparing their presentations today and sharing their ideas. We've had such a robust discussion, as I said. Many thanks to those in attendance, including the members of the International XLH Alliance and their communities. Without the participation of patients and patient groups, we would not be able to have the understanding that we have today about XLH, and we would not be able to move forward with all the research and work that is, as I said, is yet to be done. And finally, I do want to bring to your attention that tomorrow is actually International XLH Awareness Day. And just in case you're wondering how October 23rd came to be International XLH Awareness Day, it was suggested because obviously October is the 10th month of the calendar year, and the Roman numeral X represents the number 10. And obviously FGF23 is very important in the mechanism of action of XLH. And so we have October 23rd as XLH, an appropriate day to be raising awareness, and hopefully we have done part of that, or at least gotten it started in part with the webinar today and with the campaign from the International XLH Alliance that has been running on social media for the past 6 weeks. If you have not been following along with the campaign, we encourage you to go back, take a look at the content. Many of the burdens and many solutions to some of those burdens have been mentioned, or at least some opportunities for adults with XLH. And finally, I would really like to thank Oliver and Tenna for organizing not only this webinar, but also the International XLH Alliance and amplifying the voice of the patient to raise awareness of the issues that matter most to people living with XLH, and to have this conversation that will lead, no doubt, to improved care for adults with XLH throughout the world. So thank you, everyone. Good night.